Hello.
Hi, Cole.
Everyone.
Good. How are you?
Good. Good. Very well.
How's the end of your day?
Good. Ended up kind of wrapping things up and wasn't great on my point of service today, so I had a little bit of time to do that, but everything else was good. And I had a full afternoon, so
Yeah.
it's a good problem to have.
It is.
So hopefully it was interesting that had two patients at that exact same time on a Tuesday morning. I'll try to give Sandy a call in the morning to be like, and just to maybe capture her, but it's kind of,
Yeah, she didn't answer for me today, so
we'll see.
I should come back. Yep.
Hello there.
Oh,
Hello?
how are we doing this evening?
Oh, I'm good. How are you?
Good. Very well.
Okay.
Just a little FYI, when you go into the garage, you'll see a big pallet there next to your pickup. That's our therapy staircase. So
Good.
we'll
Somebody
well-
just need to clean it up because I got one of those things in my tire. So whoever opened it up, just let them know they should do a little bit of more of a due diligence. One of those things that are for wrapping got actually in my tire. I noticed that already. So
oh,
yeah, I hope it's not a flat in my tire, but whoever put it in, just spread all those things around.
yep,
Yeah. Okay. Well, let's not talk about that now.
yep.
So it is 6 o'clock. Let's start.
Yes. I trying to open up here. I guess, does anybody have anything or kind of questions for Dr. Abbasi, kind of anything kind of collaborating over the last couple months with patient care or anything like that, where it comes to specific protocols or tough patients, that kind of stuff, kind of questions?
I think we should have that. At least 3 people present a case, maybe a challenge, and we should make it to a routine that 3 people present the case based on the information that then we can expand. And I can talk a lot, but I want talk about things that you guys like to hear.
Mm-hmm.
So do you have yourself a case, Cole?
With that, there's a couple of patients that I've worked with that recently that they've dealt with just a lot of chronic pain, almost kind of central sensitization, and just overall their nervous systems are so heightened that even with the smallest, lowest levels of exercise or activity, it flares them up to such a significant level that it's hard to manage sometimes. So
Yeah.
On your side of things, what are your advice for, I guess, for therapists? I try to incorporate some pain education in there, but do you have any kind of tips or tricks, I guess, as a therapist, to how you've managed those kinds of patients that just have so much sensitization?
Yeah, well, do you have a specific patient in mind? Then I can give you a specific information regarding that patient.
Yep. So a patient today that I saw was Nikki Jo Eichhorn that we worked with.
Everybody knows her. So first of all, many of our patients, that their spine problem is not their only problem. Like with Nikki Jo, she has significant psychosocial problem. And you have noticed that it's just very hard to communicate with her even, because she just talks, and she has probably ADHD. Not probably, it's very likely that she has ADHD. and she cannot stay on one topic. She asks you a question before even she's done, not even letting you talk. Before she's done asking the first question, she's already done with that. She's asking the third question and so on. And focusing her on the problem is very hard. Now, this is a special case. I think there are only 5 patients like that any practice can manage. If it's more than 5, you can as well close the door. Okay, so now she's a special case, but you get as well lots of patients that you touch them, they are in pain, and sometimes they are. That sometimes they are truly, you may have noticed that I have a brace on today. I had a brace on, and sometimes even smallest kind of motion, it just catch me. I just want to go on my knees and quit breathing. So I can sympathize with those patients who have that kind of pain, but you have to start somewhere to find out what is not painful for them. Somehow they made it to your office, right? Find out how did they manage to make it to your office, and start with those activities that got them to your office, and then activate. And that is something Nick needs to talk to, not I. But then you start with muscle groups that are adjacent to those muscle, and then find out how much can you push them. Range of motion is a good way to start to see what can they take, and then you let them have that range of motion with some activation of the muscle groups, and then just build on what's there. Mm-hmm. Now, once, and you as well, there is almost impossible just activate one muscle group. Like, if you're checking your biceps, you're automatically activating their triceps and so on and so forth. I'm exaggerating now, but I know when you go to school for 4 years, they teach you what are the 5 ways of activating one muscle group, and then each of them will require other muscle groups to activate. Mm-hmm. Eventually, you will run through them, and you have done your job. Then you send them back to me and say, this is all you can do. Mm-hmm. Okay? But Nick, that is, I think your input is very highly appreciative here. In a case that everything is painful, and sometimes it is legit. What do you suggest to do?
Well, I think you hit on a couple topics I really like the practical application of showing them what they've already accomplished just by making it into the practice. Shedding light on what they're capable of doing, because sometimes when they're not so intentionally focused on one particular movement, they're capable of so much more than they believe. Mm-hmm. The other, from an interventional standpoint, I think one aspect of P&E that gets kind of forgotten about is graded exposure. So letting them, visualize you performing the activity sequentially before really having them do it even at the lowest level. That's something that you can sometimes lead them to see it, and thereby open the door for them to believe that it's capable, and what their possibilities are, what they're capable of doing. Mm-hmm. And I've had good success starting with using a moderate weight, for example, or even heavier ones, and then stripping back down and saying, now, I've just demonstrated good form, done it multiple times for you, talked them through it, cued them through it. Now, let's take you through something incredibly lower level and then build you up there. But that graded exposure activity, I think and that goes for whether you're doing a floor to waist lift, waist to crown, or even just a walking program. I think those things are effective.
So I can give you as well an example from other things that I do to just build a connection to the patient. Many times, mm-hmm. It is just building a connection, a trust relationship. If they come and you start with the activity that's painful, then you have a lot of catching up to do. So what do you make them just first of all feel good, just to be around you? Well, now like cold and hot, massage, ultrasound, and so on. Even, acupuncture. No study has shown that, cold or hot will do any long-term difference, but that make them feel good in the moment. Once they feel good in the moment in your present, it is like conditioning kind of things. They just you have a already better starting point. For some people, it is just, giving them a little bit of it. Do you guys learn that, the chiros are really good at that? Do you guys learn like deep tissue massages and so on for loosening
Yeah.
spasm and so on? No,
Yeah.
sometimes, I'm just telling you, no, I'm aware of no study that after a spinal fusion, deep tissue massage is going to change the outcome. But I know that it makes them feel good. And we know if they feel good, that is a study. That is not a gut feeling.
Yeah.
If they
Yeah,
have a
absolutely.
positive attitude toward their problem, the outcome is better. So meaning that in a case like everything is painful, just put them somewhere in a comfortable position and just massage the spasm out of those, or ultrasound,
Yeah.
or hot, or
Yeah.
cold
And
works.
well, even taking that step further into some that's more research based, but you could even do that for hypersensitivity to desensitize the tissue, because they a lot of the cutaneous structures might just be that hypersensitive. So doing some tissue work does help them desensitize. You mentioned something, doctor, that I've only done a handful of times, and I forget about this, but we always give people home programs. And one thing that I found to be successful, right after one of those Adrian Lowe courses, I'd give them additional piece of homework before they came back to see me, was to write 3 to 5 functional goals that they had, because we go through our goals that first day, and it's one more piece and we're just kind of hammering through it. But send it home with them and have them bring it back in a notebook and be more intentional on it. And that was pretty successful, because then it gets them thinking around their house, like what have I been avoiding? What have I not been doing or accomplishing? And you just build a stronger relationship with them, because they come back in, and if it matters to them, hopefully you can help them do that and accomplish it.
What I have noticed is the worst thing you can do is asking them to toughen it up. Again, it get me sometimes still on my knees, and it's a specific activity. Now, I'm a professional, and I have almost figured it out what it is. I think I have a multifidus muscle tear in my back, because when I start, doing literally depending on it, it get me on my knees. Now imagine I'm a professional, how much harder it is for the patient to figure it out. Now you should, I'm sure you have it. If you don't, put them through a certain routine to see what muscles are most painful. And in my case of my surgery, I can tell you, I have to poke holes into paraspinal muscle, not multifidus muscle, but paraspinal muscle, because I come at an angle. And as well, for sometimes, even though we try to stay posterior to iliopsoas, sometimes we still poke holes in that. Some iliopsoas wouldn't be unusual. And as well, some of the oblique abdominal, when I put my cages through, check them one by one to see what muscle is most painful. It is not an unreasonable request on me to send them back to me to just trigger point inject those muscles for you. So you have in the next few days or weeks a little better of a easier path to go. If you can identify, that paraspinal muscle or multifidus muscle or rectus abdominis or iliopsoas is painful, it is not unreasonable to do some trigger point injection to ease your path through that thing. Okay.
Yep, and with that too, that's something that's we've been luckily been able to start to incorporate in our practice too. Where I've recently got certified in dry needling, so I mean I can go in with the dry monofilament needle and kind of find those trigger points. And I agree, that's definitely the patients that have been willing and appropriate to try that definitely have seen a lot of good response to that.
And I think one of the most important things that they very rapidly benefit from is that, like what Nick was saying, I appreciate that, Nick, is about the daily activity at home. What is it? What you need to do, what you cannot do. Don't try to make them all better. Try to make them on that specific task. Putting the socks on, this is, for me, was a hell just to put my socks on. Now I figured out a way to do that. Literally, what it's hard for me to bend and do that. I put my leg on a chair without arm, and then I sit on it so I can on the side put my socks on. I suffered literally 10 days before I figured that out. If you could show that to me, you would be my best friend. Okay, so what I'm getting at, concentrate on their actual daily needs rather than, and that can be different, and once you have that kind of connection and make their life easier, they will be so much more receptive. At the end of the day, there are certain group of people like Nikijo, you won't get anywhere. But you still go through your routine, but I guarantee you, those are very, very rare situations that people are like that. Now, I like as well in one of our next meeting to bring some personal trainer and yoga instructor to get their perspective, to get their, the view on that, not only teach them, but as well learn from them, what other things do they have? Now we are getting to an age that you guys do whatever you guys are trained to do. But and I can tell you from me, if you tell me how I manage diabetes, or even how I manage things that are related, like shoulder, which is connected right next to the spine, I'm absolutely ignorant about what things are out there. So we get so specialized in what we do that we neglect anything, even if it's so close to it. I think, I'm always open to have a multidisciplinary, hear from interventionalists, hear from chiropractors, personal trainer, yoga. What problems do they deal with, and bring their expertise as well to utilize. For some reason, like if somebody is up into yoga, if you show them an exercise that's emulate some yoga training, they will be so much more receptive, because not only they have a training, they have a good experience with that. And that, so utilize things like, I'm telling you what I'm doing. Sometimes I put a needle this big in people. Do you know what I do before? I try to massage an inch next to it. That sort of take their attention a little away from that. Do you know who I learned it from? From my dentist. He massages my cheek before he put the numbing medication in. And once I pay attention more to that, his massaging is so much more pleasant, so much less painful. So I learned something from my dentist. Then I guess then we can all learn something from chiros, personal trainer, yoga, and having a multidisciplinary kind of approach. I think it's going to ease up for those difficult cases to add more to your toolbox, okay? So that was actually much more than I was expecting to learn from Nikijo, but that was a good one.
Oh, thank you.
For people who don't know Nikijo, I'm on the way to see her today in my office. In a way, I was wishing to have a heart attack so I don't have to go to that room. This is how difficult she is, okay? And if you that is that she's at the peak of how much stress she puts on the providers to take care of her, and by doing that, she really is sabotaging her own care. But sometimes these are the patients; they are not professional. We are. You have to deal with them. So, Lauren, do you have a case for us, Lauren?
I do. It's actually more so about progressions for your protocol, but I see Tony has his hand up. Do you have something that went along with that?
Oh,
Sure. Can you hear me all right?
yeah.
Good. I was just gonna jump in on some of that. I think the importance of on kind of the chronic pain and figuring out where to start. The importance of the thorough exam. It's a little limited, of course, if you're post-operative, your exam is a little more streamlined or whatever, but just making sure we're taking the time to listen to the patient. We're one of the few professionals that has, an hour exam, and then we have some time, repeated with the patient to just kind of listen to their issues and develop that rapport. But through that thorough exam, like sharing the negative findings and the things that are going right, start to build their trust in their body again.
Yeah.
And I find it's just as important to, or more important to share the negatives than the positive findings of the exam back to the patient to help them reduce their fear, anxiety, and kind of that test retest. That's part of the EIM model. When you test something that doesn't work or test something that you think they might be able to do and then retest and show them the minuscule improvement, even if it's not much, it helps build your just helps build their trust in you and their ability to have some confidence in what it is that you're doing.
Yeah.
Once you that perception of you as kind of the expert, that you can help manipulate things in their favor, then things start to snowball in your direction.
Yeah.
I like Dr. Abbasi said too about the shoulder. Oftentimes we can start peripherally, even if the issue is at the spine, mobilizing the distal nervous system in a way, using sliders that desensitize things, in order to start there. Or there's plenty of times when I see an orthopedic surgery patient that has a referred spinal pain, or vice versa, they have spinal spondylosis, which they had their surgery for, but you can bet they have arthritis in their hip and knee. And if you can improve range of motion at a peripheral joint or help them feel better somewhere else, sometimes that gets me the start I need just to have a win and move in the right direction.
You guys have noticed that most of our patients come to you about 2 weeks after the surgery. Have you ever wondered, why not right next day after the surgery? You remember said everything being painful, and then you cannot do much. That is what we have found with the time, that about 2 weeks after the surgery, when not everything is painful, that is where you have more things to work with. And now, preferably, I want them to come just next day after the surgery, especially learning about things to do and how to do things. But we have found a good way. We want them to learn that before the surgery, what to do, how to do things, when they don't have a pain, when not everything is too super painful. And this is something that we can revise. If we decide as a group we want them to come to the physical therapy right now, 2 days, 3 days, 4 days after discharge, this is what we decide. But if you have any input regarding what is a good time frame is that you can get the maximum benefit from physical therapy, please go ahead, Nick.
I was gonna just on that note, because we not only just historical data across broader pictures, but also having taken my mom in for the first 3 weeks last year, I do think there'd be. I agree with you. I don't think the outpatient model is the right way to go. But whether it's probably a home health evaluation or telehealth in the home at first, just to help them functionally show some improvement and gain some ground. That would be my advice. Maybe it's day 3 or 4 post-op. Let them get through that, because that really helped her get over the hump. As much as I was helping her out, she needed to hear from another voice, and also get on the path too.
How many days after the surgery did your mother start physical therapy?
Well, I think we set her up with telehealth Cole probably 5 or 6 days after surgery. She was really, and she did have a more invasive process than was anticipated, multi-level fusion. But I think that really helped in that situation, particularly because she was, a lot of this, and no different than other patients that I've worked with, where, they can fatigue you out by asking you the same questions over and over. Here, my mom was doing the same thing with me. Is this normal? Is this normal? And why am I having this pain? And why is it, particularly nerve pain? But the more mobility she was able to get, the better she was. And she started making bigger gains.
I'm hoping that, the reason I'm sending the patient before the surgery to you is that you can go, you see, when patients in pain, the brain is not receptive. In a way, that is the reason they ask the same question 20 times. Well, and no matter what kind of surgery it is, at first, it can be actually you should see those screws I put in. So it will be pain associated with the surgery itself. So we should involve some of our routine to answer those questions about what is it normal, what is it expected, even before the surgery in those sessions. And definitely we should give the patient the option to have a telehealth. We can set it as a routine that we can incorporate to give them a option. But the question is, eventually they need to, almost all of them, they are going to see you. When is the time? When is the maximum? When can we get the most benefit? Because they have to drive to you.
Yeah.
Right? So after the surgery, they will feel every pothole there. we have to find out what is the sweet spot. Traditionally, that has been 2 to 4 weeks after the surgery, that sweet spot that they benefit from all the things you are doing, because in truth, they would benefit from all the things you are doing just the day after their discharge. But there's a downside to that as well. They're not as receptive. They're on medication. Their mental status is low. They have to drive. All those potholes and so on. And they have to come and see me 2 weeks after surgery, or 4 weeks, 2 to 4 weeks after surgery. Anyway, we can still decide what that time frame is, and what we can do for them in that time frame. But that is, I think, to ask around that, what is it the time frame that you guys think is the most beneficial, and then how we can fit that there. Lauren, it's your turn. I want to know about your case.
Sounds good. So my case is actually higher level. So it's one of your Burnsville patients who is a marathon runner, and she's getting an OLIF, but wondering.
Is it that 72 or 3-year-old
Pamela?
female that her life is all about marathon?
Yes.
Okay.
So, and I understand, I've run many half marathons, so I understand the love for it, but just wondering where your opinion is on return to sport, how soon, as far as post-operative on that.
I love this, because now I'm going to you gave me opportunity to show you that I think I should have shown you long time ago. This is recording. I truly recommend you let the rest of your team as well watch this. Your question is about how to deal with people that you want to perform at the highest level, because I'm 20 years younger than her. I couldn't dream to run a mile, not even 5 miles or a marathon, but that's all what she cares about, right?
Yep.
If I cannot make her run the marathon again, no matter what I did, I'm going to be not successful in her book. So let me show you something. And this is a problem that you and I may not be able to solve together, but for this patient, for this specific patient, but this is a problem that we can solve for the bigger community if we put our heads together and, to start addressing these kind of problems much longer before this becomes a actual problem for any individual patient. So let me open my presentation, and you guys are going to be good at that, because when I start that, I make it a conversation. Master. Here we go. No, I don't know which screen I should share. What do you guys see?
See the OLIF, all you need to know.
Okay, here you are. Now, do you see the whole screen, or do you see still the background?
I see your whole desktop with a small PowerPoint on it.
Okay. Now, do you see now the instrumentation, or do you see still the transcambine oblique lateral? What do you see right now?
Still the transcambine oblique.
Oh, okay. Then I may have to switch it, because that's not what I want to show you. Okay. Unstop sharing. Okay. Screen share. Okay. I think now you're going to get the right one. Okay. Do you see a back of a person?
Yes, and hardware on the left.
Good. Okay. Now, so let's say we are born and our spine has very little function, right? And then when we die, hopefully 100 years old in the loving embrace of our family, our spine has zero function, correct?
Mm-hmm.
So We start with 0, we go to 0. When do you guys think we have the maximum capacity function of our musculoskeletal, especially spine? What age? Lauren, you start. What age do you think we have the maximum capacity?
Oh, 25.
Cole,
16.
Tony. Tony,
23.
Nick,
Well, based on your smirking, maybe I'll go a little north. I'll go like 33.
Now, do you know how to look at that? Look at the Olympic gymnastic. How old are they?
Like 16, 17 years old.
12 to 16. That is where you have the maximum capacity. Lots of people say 25 because most of the athletes, professional athletes are in 20 to 25. But what you forget about, they have to build skills. That is not big. They're not, most of the professional athletes are in 20 to 25, not because the maximum capacity is there, but because they need time to build skills. But this is 12 to 16 is, by the time you are 16 years old, for Olympic gymnastics, you're too old. Now, obviously, there is a path that, you need help, you don't need help. Most of us, we don't need help until we truly fall below 15 to 25% of our capacity. And obviously, that's why it's important to put your kids to go do sport, because if you don't have good childhood habits, you don't build your capacity, your 100% is not as high it can be, meaning that you will fall down after that. And if you don't have a good childhood kind of activities, you will need help by the time you're 60, not by the time you're 70 and 80. So you're building reserves, okay? Now, the same way, if you have a good spine habit, you can push the curve more to the right versus if you have bad spine habit, okay? Now, this is what the spine, what we can do for people, for our people. Like for that marathon runner, she has always a good thing, and we can give them healthy habits, push their curve more to the right, keep them more independent. Now, this is what we have to start early though for that, right? It's by the time you're 70 years old or 60 years old, it's too late. Now, but that is what the spine disease does to them. Like this patient she was 70, start having problem, and then she literally, the function fell off. She couldn't do anything. She was dependent, okay? Now imagine this is the healthy curve, and this is the spinal disease. Like she had a surgery, right? Now we fixed her, but what did that?
Yeah, I don't know if she's had it yet.
Oh, she didn't have even a surgery?
I don't think she's till May.
Oh, maybe then we are not talking about the same patient, because maybe I have two patients, 73-year-olds running marathon. Because
I've had a couple.
Yeah, because I had one that I just fixed, and she's asking me when she can go run marathon.
Yeah.
Maybe we are talking about two different people. So, but this is what it is. I'm going to be able to make that, treat them faster, because my surgery, other surgeon, they tell them you're too old, you're too young, you're too big. They cannot give them the surgery, but I can. And by the time they get the surgery, they never catch up. And the surgery itself is so damaging. We destroy most of their musculoskeletal in the spine. They never catch up. But I can give them, and they're told it's too risky, and then we ask them not to do, and then not to do the surgery. We push them away from our practice, and then they end up with a cardiac disease. They get, when you cannot walk, you're literally deconditioned. You guys know that. And you do it fast. And they don't go and live with the pain. They go and die with the pain. But what we can do is we can give them that surgery. I'm just going to here. We can catch them, put them through a protocol, if nothing else can help them, I can give them the surgery and bring them to the natural curvature of the spine development. Meaning that with our protocol, even maybe a little better than their usual aging process. But sometimes people come, and I'm going to go here now. You see, this is our curve, how we can help them. This is the open surgery, and this is needing help for daily activity. So we can do really lots of good work, and that good work is actually, there's a name for that. Do you guys know what that name for is? That we regain them quality life here. Who knows what that's called? It's called QALY. And according to Center for Medicare, every year of QALY is worth $94,000. So we can do lots of good work there. And even for people who are not qualified, we can still do lots of work because our surgery is not too risky and so on. We can still help them. But this is now again the curvature. This is need help, don't need help. This is the bad childhood habit. This is what we can do for them if they get involved with us. This is what we do for them, moving them from bad curve to good curve. And even if they have disease, we make them healthy. And now sometimes, let me go back forward now here. Sometimes the people come and ask me, here, they come here, they have a disease, they fall off, I correct them, and now there are a few years later, they want to still run the marathon. You know where I'm going, Lauren? Do you understand where I'm trying to go? They want me to put them back where they were like 10, 20 years ago. They're asking for this curve. Do you know what we call this curve? We call this Benjamin Button curve, because they asked me to make them younger. And there's another name for Benjamin Button curve, the eternal dissatisfaction curve. Okay, so if that 73-year-old person is expecting to be running marathon, if that's the only thing giving her joy, you and I, we know it's just the time is ticking for the time that she can do marathon. As a matter of fact, she's probably one of 5 people in maybe in the state of Minnesota in her age group that can even run half a marathon. Because there's just not a way to keep people young or make them younger. So the question you have for me, the true question you have for me is, can she run marathon or not? And the answer, maybe dissatisfying for her, is we can make her as just before she started having this problem and put her on the curve of what her age would be without this problem. And we are the closest can do that. No other surgery can do that. But we cannot take her from now, put her back like how she was 10 years ago. Now, is there a good way to tell her that? Not anymore, because right now she's all focused on that marathon. And the worst thing you can tell her is that you will never able be to run marathon. But what you can do, dangle that like a piece of prize out there for her. Say, even if you have to lie, it's a possibility, but we have to get there slowly. Why don't we put achievable goals? Like, now walk half a mile, walk a mile, walk 5 miles, and then fast walk. Put the goals that are achievable there, because as soon as you tell her you will never be able to run marathon, she quit listening to you altogether. So internally, in a way, it's not deceiving the patient, but putting achievable goals. And you and I, we don't know, maybe she can run marathon. Statistically, as though it is unlikely. Okay, so not sure if that gives you what you were looking for, Lauren. But the short answer to what you're telling, what you're looking for is, we can put her on a normal curve, but that normal curve doesn't, but for most of 73-year-old people, doesn't include running marathon. For her, the best practical way to deal with her is to dangle that goal somewhere out there and say the best way to get there is never say definitive yes, because then they come back and blame you for that. You say, you always put it out there, like it is like you're taking hostage something. No, truly, it's like a negotiation, game theory. It's a negotiation. You never say to the hostage taker no, because they shoot the hostage. In this situation, if you tell them no, you lost their relationship, you lost the trust. But you always give them an alternative. They say, I want a helicopter. You say, that's very hard to get a helicopter, but I'm going to start working on it right now. Just keep everybody safe. You tell them, that is a fantastic but big goal, to run a marathon in 1 year. Why don't we start on walking, having 5 times a quarter of a mile small walk, and build the muscle that you require for that? Then let's walk half a mile. Then let's walk a little faster. Time yourself, but make sure if you have pain, you have to dial back. Let your body decide rather than we mentally force it upon your body. And let's build toward that goal. And again, I think you and I, we don't know if she can do that, but let's use it rather than that comes and hammers us and prevent us to provide the care. Let's use it as a tool, as an additional tool, to give her the proper motivation to work through the routine that we know it's good for her. So what
Wonderful,
question,
thank you.
yeah, what other question do you have regarding this specific patient?
Nothing on this specific patient. I've just had her, 2 marathon runners, I suppose, and then one that wants to be able to lift more than 50 pounds.
Yeah.
So the protocol we have set right now is 35 after 6 months. Are you okay with them gradually progressing back to that normal amount?
Generally, they have done those studies. Even if you don't bend, even if you don't lift, when you bend, by the way, who said that 16 years? That was the closest guy. Who said 16 years? Cole. Okay, you get a cookie from me. Okay, next time I see you.
Thank you.
Now, they have done those studies. Another trivia. When you bend, just when you bend, how much pressure do you put on a vertebral body, on the disc itself, in pound or kilogram? If you are, let's say, 70 kilogram, 70 kilogram is 150 or 160 pounds. How much pressure do you put on that disc? Let's go again the same way. Lauren, what if a 70 kilogram person bends 90 degree, how much pressure does he put on a L4-5 disc? Throw a number out there, nothing wrong.
Oh, I would say at least 75%. So that would make it around 120
120 what, pound or
pounds.
kilogram?
Pounds,
Okay,
60 kilograms.
Okay, so Tony, what do you think?
Sorry, I'm muted. Let's go with muscle contraction, put it more up at 105 kilograms.
Okay, Cole, what do you think?
I'll go 250 kilograms.
250 kilogram. Nick?
I'll go with 251 kilograms.
Okay.
Pricey.
This time you are closest, Nick.
Oh.
The
What's
actual
that?
number, you're the closest to the actual number. The actual number is 1.5 metric ton. The weight of a car. Now, you may wonder how a 70 kilogram person can produce 1.5 metric ton of pressure on the lumbar spine. Any ideas? Lauren, how can a 75 kilogram person put a 1.5, this is the actual number, 1.5 metric ton of pressure on L4-5? What do you think?
You're saying how as in position?
How is it possible that a 70 kilogram person put 1.5 metric ton of pressure on L4-5 when he bends?
I would say just the straight flexion position without any leg.
One
Move.
possibility could be that I'm just making it up. That could be still one possibility, right? So Tony, what do you think? Am I making it up?
That's an interesting question. I would say just the physics of the lever angles and the muscle contraction.
Perfect. Okay. Imagine you have a lever that the length of the crowbar, that the long lever is like what, 2 feet or 3 feet, length of the vertebral body up to the head. And the short lever is the length or the depth of the vertebral body. That is how you break big doors. You put a crowbar and use the long arm to lever the short arm and magnify the force. Okay? So now, when we started this conversation, it was about, how much to lift, what to do and what not to do. Now, this is 1.5 metric ton without lifting anything. If you add like 20 pounds, if you bend and add 20 pounds, you're not adding 20 pounds down there. You're magnifying that 20 pounds down there. So let's go at one level. That's sort of amazing how much our body can actually manage. I come back to that, but when we do a discogram, we increase the pressure inside of the disc. Sometimes we measure it. The disc, you can go up to 120 psi with no problem in normal disc. That's 3-4 times more than in car, entire of your car. Or disc can take that much pressure. But now, let's go one level farther. Let's put twisting into that. Okay? So, how does a screw work? Literally, the mechanic of it. Have you ever thought about how does a screw work? Or how is it that you can, with the screw system, lift up a whole building, like literally put a thing and put a lever and just turn it little by little? Have you seen those devices that they lift the building with just a mechanical thing? They put something like a screw system and they just turn it little by little. They lift up a building. Now imagine twisting is like a screw. Like take a wet towel. What is the best way to take the water out of a wet towel? Twist it, right? So twisting or screw system produce 10 times more force than even the lever. So now that is why we tell them don't bend, twist, and lift. Now, if you go to airport, if your luggage is more than 50 pounds, you have to pay extra fees, right? You know that, right? You know how they justify that? Because they have to pay 2 people to lift it and transport it than 1 person. That's how they justify for you to pay more. In truth, we all know they still don't pay an extra person. They just charge the money. But that is how they justify that. So I don't recommend to anybody to lift constantly more than 50 pound bending, twisting, lifting. And for a simple reason that more you put it at that level of stress, you're shortening the life expectancy of that disc. We all know you cannot live like that. You have to do those things. But then where you come in play, you build more muscle in the spine that can manage it without passing the energy to the spine. That energy is managed at the muscle level if you have a good dynamic. And if you do it in a better way, that is all the good things you can do. So let's come back to your question, Lauren. When can my patient lift more than 50 pounds, especially if they have to lift additionally just to bending? So what do you think what I'm going to say about that?
Case by case basis, if they have the strength to do it,
I
good
don't
mechanics to do it.
I don't recommend it. I don't recommend to Nick, to Tony, to Cole, to you.
More than
You
50.
can spend more than 50 because
Okay.
that is a recommendation based on long studies. If you
Mhm.
have to do that in almost every workplace, there are rules in place that, as a matter of fact, you have to prove to your worker comp thing and so on that you don't let the patient, your worker, to do that before they insure you and so on. If you have you have devices, if you have those things. In truth, we know that in many jobs, there's nobody else around and so on. We have to do that. In those cases, the best option you have is do it the right way, by proper mechanic and so on, and don't combine lifting and twisting and so on. But that's where you come in place. But me as a professional, I recommend it never to do that. I don't recommend it before the surgery, and I don't recommend it after the surgery. But
Okay.
if you have to do that, your best outcome would be if you do it after you know how to do it the best way, after you have visited the physical therapy, after we have gone slowly, very slowly up
Mhm.
to that level. Does that answer your question?
It does. Thank you.
Good. Now, who set up this meeting? The Zoom conference of this meeting?
I think Mike.
Mike? Okay, then I will have the record of that, or Mike will have the record of that. I think we covered lots of good information here, okay? So I really recommend to you now that get the link and share it with people in the rest of your group, because I doubt that this is anything that we discuss is only your question and not others, okay? So any other item you guys like to discuss?
I was just gonna, just for verification, what you just said, you're saying, so lifetime expectation for a patient post-surgical lumbar spine, you're saying nothing to exceed 50 pounds.
No, I'm not saying that.
Okay,
You
that's
know,
why I want this clarification. This is good.
no. See, I as a surgeon, after fusion is happened, I have no other limitation from surgical side. You see that's one of those things you ask somebody, I neither deny or
Yeah,
confirm. You see that there? I'm
by omission.
keeping myself on the safe path by saying there is no additional limitation from the surgery.
Okay.
But can you go and fly? No, well, yeah, if you can fly, go fly. Can you go and, move, lift up a whole boat all by yourself and so on? It's a little, doesn't sound healthy, but the surgery is not the reason you can or cannot do that. You get where I'm going?
Yeah.
And that is what sometimes professionally, all what we can be. Tell them, but is it recommended generally for a person to lift more than 50 pounds constantly? It generally is not recommended, but that has nothing to do with what I do, what you do, or my treatment or your treatment. Okay, because as soon as you tell them you can never lift more than 50 pounds after the surgery, they associate that with the surgery of where you
Danger. Yeah.
and so on and so forth. So we don't want to do that. We don't want to give them the false impression that that has anything to do with what we did. It's just part of the human and based on studies and so on and so forth. And it's like tire of your car. It all comes back to that. Is it recommended with the tire of your car for you to drive on sharp glass and stones? We just know, as a matter of fact, if you do that, you will have a shorter life expectancy on that tire. And it's more likely, statistically more likely, that you will have difficulty. In a way, patient asked me, doctor, I heard that if I have a spine surgery, then the next level goes bad, then the next level goes bad, then the next level goes bad. My answer to them is, There's 3 reasons for a disc to go bad, like the tire to go bad. Is it a good tire or is it a bad tire? That's your genetic. The second reason is aging. Even a good tire, after a certain amount of mileage or time, will be flat and go bad. And the third is how you use it. Are you driving on a regular road, regular speed, or are you driving off-road on sharp stones, high speed? The only third thing is what people have literally any influence on. Now, people cannot change their genetic, they cannot change the effect of aging, and they don't want to really change their habit, and they're surprised why you fix one disc, the next one goes out, then the next one goes out. And if you notice, they always go bottom to top out, because the bottom one have more pressure, more weight on them, they're more likely to go out. So in a way, the people who you guys can change their life habit, that they don't bend and twist the wrong way, they will get more mileage. So after my surgery, that's one of the things I tell all my patients, that the physical therapist can help you now more than anybody, any surgeon can, and you guys can, by bring them a balance, teach them how to do the things right way. And I think by concentrating on the limitation, again, it's sort of, we put them on a wrong path. I rather not tell them what they cannot do, but and what they can do. So we are almost 1 hour into this. Oh, wow, time flies fast. When we have
if I can just have one quick follow-up question to that, and then is there have you ever experienced structurally with your screws or the OLIF procedure itself, that just purely lifting, twisting, or bending led to a revision? Or like I said, we have these protocols. Like I said, don't do these things, but gosh forbid this patient goes and lifts 50 pounds and twists with it a month after surgery. Have you ever experienced a direct leading to a revision or anything like that? Have you had those experiences as well?
And as usual, as it's my way, I'm going to give you a long answer to your simple question. Cole, what is pain? Did the Lord want to torture us? What is pain?
A perception of threat.
A perception of threat is not the threat. Pain is not the fire. Pain is the noise of a smoke alarm. In that sense, one of the dangers of my surgery is that my patient feels so good, so fast, they forget. They only feel good because those screws are holding them together. And I have this conversation with all my patients that this is a danger of what you're doing. You have to mentally make sure that you don't go over the limitation we give you. And even with those limitations, if you have pain, you stop, you go even bad. I have a patient that 3 weeks after the surgery put a 1,700-pound swing set for their grandchildren together. They loosened all those screws. And I had to take them back and redo everything. I see them, even after having this conversation with everybody, I see every week people that overdo it, loosen a screw, even break the screws. You can break those screws. And we talked about that. 1.5 metric ton of pressure. And if you repeat that, those screws are fatigued, they can break. Any of those things I have encountered, breaking screws, loosening the screws, pulling out the screws, disconnecting the rod from the screw head, and so on. Now, I have noticed, since I have put those protocols together and reinforcing it all the time, don't do this, don't do that, or do this way, do it that way, that rate has dropped significantly by constantly reinforcing to the patient. Literally, the day of the surgery, I tell them, right after the surgery, I tell them, before the discharge, I tell them, and I tell them, I have this conversation with everybody, and still 1/4 of my patients, they come and they overdo it. In most of the cases, we get a CAT scan, nothing is wrong, but that's a warning sign. But up to 5 to 10% of the patient, they keep overdoing it. They loosen the screw and so on. And listen, you're my patient. I'm telling you that that this is a bad idea. Still lots of people do that. Just by me telling them that people still do that, and when they do that, we just have to take care of them, okay? In less than 2 to 5% of the cases, less than 2% of the cases, I have to take them back and fix it. But sometimes I have to. So I could have told you just yes, but I gave you a longer answer. Okay.
No, thank you. I appreciate that.
Okay. Anything else? So if I may ask, please, for future, I think doing it every 3 months is more appropriate than doing it monthly. But please make sure that every single of you have an actual patient, that the problem that you encountered, that we talk more specific about those problems, and then and use it as well to refine our protocols. Okay. Like, I think it's a great idea, Nick. Connect with Sarah. People, should be our protocol. People who called 4 days after discharge because they are in pain, they should get automatic internet consultation with you guys. Okay. And I think that's the best kind of thing. If you call because you're in pain, you get a visit with somebody who can manage your daily activity. Would that be all right?
Yeah, that sounds great.
Okay. Okay. If no other question, it's exactly 7 o'clock. We adjourn the meeting. Okay.
Thanks. Have a great night, Doc.
Okay. Thank you.
Thank you, Dr. Abbasi.
Bye-bye.
Thanks. Thank you.
Thanks.